Okay. Well, welcome everybody. My name is Ara Behagen, and I am here with LAIVF for our afternoon webinar. Our topic for today is overcoming male factor infertility. We are going to talk about the causes of male infertility, what is involved in testing, treatment options, and of course, any questions you may have. Before we begin, let's start with introductions. We are ivfclinic.com. Again, my name is Araba. I am the practice relations.
Hello.
.com. Again, my name is Araba. I am the Practice Relations Director. Joining me today is Dr. Aykut Bayrak. He is the Medical Director, founder, and owner of LAIVF Fertility Center. Dr. Bayrak has been in practice since 2005 and is double board certified fertility specialist. Welcome, Dr. Bayrak.
Thank you, Araba. Can you hear me? Your connection was a little bit it was breaking up a little bit. Can you hear me?
I can hear you perfectly.
Yours is breaking up a little bit, so let's just make sure you have good connection and everybody in the room can hear you.
Okay. We have a few people that are in the room so far. Okay. A few more are joining us.
Sure.
If anybody out there cannot hear me, please let me know. You can put comments in the chat area of the webinar. Okay, and also to our listeners, please feel free to ask any questions. You can do that by putting your questions in the chat area as well, and I can go ahead. They'll come to me, and then I'll go ahead and ask Dr. Bayrak your questions. So to get started, somebody just wrote in, said that they can hear me just fine. That's great. Thank you so much.
Yeah.
Okay. Wow, let's get started. Dr. Bayrak.
Yeah, let's start.
Let's start with kind of the overview of the male factor for infertility.
Absolutely, Arba. Thank you for the introduction. So we're continuing on with our webinar series, and I think an important subject that always comes up is male factor infertility. Mm-hmm. Male factor actually is a very significant proportion of overall infertility in couples. And some have postulated that just solely male factor is actually involved in about 10 to 15% of cases, but as an impact, it probably impacts at least about half of our cases, probably about 50% of the patients we see. There's some level of male factor infertility. It may be mild or moderate or severe, but it impacts probably about half of the cases. The first thing that we do in the male evaluation is a semen analysis. Semen analysis is just basically evaluation of the sperm under the microscope and checking the volume, checking the pH, checking the viscosity, how thick or thin it is, checking the color, checking for the presence of white cells, red cells, checking for infection, checking the volume is important, and most importantly, the count, how many sperm are being produced, is probably one of the most important variables of semen analysis. We also check the motility, which is the swimming ability of the sperm. And then last but not least, we examine the sperm under the microscope, and we determine how the sperm appears. We call that the morphological assessment of the sperm. And there is internationally accepted criteria that also has been endorsed by the governing bodies in our country as well as throughout the world, and by the World Health Organization. And based on that, there are the bare minimum numbers. So the bare minimum number in a semen analysis, in terms of the volume, should be about 1 to 1.5 cc's or milliliters or more. The count should be at least 15 million per milliliter or more. The motility, which is the swimming ability of the sperm, should be at least about 40% of the sperm or more. And the morphological assessment is the appearance of the sperm. That is based on very strict criteria. And if the sperm looks perfect, just simply perfect looking under the microscope, and just about only about 5 or 10% of the sperm is looking perfect under the microscope, that is considered as a normal appearance, normal morphological assessment. So those are the major variables that we look at. And whenever a couple comes in or a single individual patient comes in, they say, well, I would like to check my sperm. How do you do that? We do that in our own laboratories through LA IVF clinics. And the way that we do it is we actually do a more kind of old school type of technique where we do a manual count. So we don't use a software or a computerized way of examining the sperm, but rather our laboratory staff and our technologists actually take the sperm and they do an individual analysis and a manual count of the not only the volume but also the count and the motility. And then sperm is then placed on a on the microscope. It's examined for morphology, and we stain the sperm to make sure that we can see immature sperm, mature sperm, sperm that's dead, sperm that's really active. And under high magnification, we examine every single sperm to determine which ones are normal, which ones are abnormal. So in our laboratories, typically, we believe that the sperm analysis is more accurate than just the automated way of examining the sperm. And with that, we have a much more detailed and better understanding of the sperm. So if the semen analysis is normal, and if there are no other risk factors on the male side, then we typically normal and we don't investigate further unless everything else comes back normal on the female side. Then that's called unexplained infertility. But most cases, if not all, where the couple is labeled as having unexplained infertility, we almost always find a reason. So we almost don't believe that there is unexplained infertility, as a matter of fact. But in terms of the semen testing, if everything is perfect on the sperm side, and truly everything is perfect on the female side, excellent egg reserve, no endometriosis, pelvis is normal, tubes are open, everything is excellent, then we sometimes do more advanced testing on the sperm, where we look at the sperm DNA analysis or DNA fragmentation. This is a more advanced test, and some people prefer to call this a quality test. And that quality test, it looks at not the numbers really, but how the integrity of the sperm DNA is. Sperm is still collected the same way, but it's processed differently in the sense that it's treated with a certain way to see if the DNA will hold on to its integrity, almost under stress. And there's a certain acceptable fragmentation of the sperm when it's exposed to a certain environment. And when that happens, we look at that percentage. And if the fragmentation is really high, then we typically say the quality is low. And the numbers may still be okay. So quantitatively, the sperm may be okay, but the quality may be abnormal in those cases. And that can actually affect spontaneous conception or conception with an insemination treatment or artificial insemination treatment. And in most of those cases, they're typically, those couples and men are typically better served with IVF treatment, whether that's with or without the ICSI method. IVF typically becomes the better option. And in majority of those cases, ICSI is utilized, and ICSI is the microinjection of the sperm that is chosen under the microscope by the embryologist. And one by one, then those sperm are injected into the eggs. So those are the two main testing that we do on the sperm. One is the semen analysis that everybody gets. That's more of a quantitative analysis. We look at the numbers, and it's really not a specific test. Whereas if there's any need to do more advanced testing, then we typically do the sperm DNA analysis or sperm DNA fragmentation index. And if there are sperm abnormalities, the count is low, or there's no sperm, for example, then we do more in-depth screening or testing of those men by doing hormone testing to see if they have a hormonal problem. They get an examination to make sure that they don't have any organic problems, lesions, masses in the testicular tissue. There's a common abnormality in the testicular and the scrotal area called varicocele. This refers to dilation or swelling of the blood vessels that bring the blood back into the heart from the testicular tissue, or they're called veins in medical terminology. And these veins actually can be engorged, they can be swollen, and they can increase the heat. And that can certainly be detrimental to the health of the sperm. So that must be examined. And if there is a large varicocele or a dilated blood vessel in the presence of abnormal semen parameters, then consideration can be given to surgical treatment or embolization of those large blood vessels, which can then improve sperm parameters for a period of time, and in some cases indefinitely. And in others, sometimes it just gives that little time period where you see the improvement, and oftentimes in severe cases, the abnormalities actually can come back, interestingly enough. But it does give us that window of opportunity where we get healthier sperm, more sperm, and better quality sperm, and possibly with normal DNA fragmentation. So those are the two main tests, the semen analysis and the sperm DNA test. And if everything is normal, then we typically don't do any further testing. If there are abnormalities, then we do the hormone testing to see if there's a hormonal problem, physical examination to see if there's a varicocele, there's a mass, there's some kind of an abnormality. And then furthermore, in severe cases where there's absolutely no sperm production or there's very low sperm production, those individuals will then need genetic screening. We have to check their chromosomes, and then we check specific gene problems. We call them mutations. They're almost like potholes on a road. It just happens to be in the DNA. And we can check on those with specific testing that we offer to make sure that they don't have those genetic disorders. We also do offer genetic carrier screening to those men to make sure that they're not carriers of cystic fibrosis, for example. And there's a cross correlation with men who have a specific type of sperm abnormality and cystic fibrosis carrier status. So we do test for all of those, and if there's a problem, then we obviously can address those issues. In terms of the treatment, let's talk about treatment, and then I would like to also leave some time for questions, Arba.
Yeah.
The treatment is typically directed based on the cause. So we just don't want to offer a couple just insemination treatment or IVF or ICSI, excuse me, because they have abnormal semen parameters. At our clinic at LAIVF, we really specialize in diagnosing the underlying cause. We really want to know why somebody has no sperm, for example. If somebody comes with no sperm, I want to know why they have no sperm. Is it a blockage? Is it a hormonal problem? Is it exposure? Is it genetic? Is it from birth? Is it hereditary? Is this something that they're going to pass on to the next generation, to their sons? Do they have any genetic diseases that they may be at risk of passing down to the next generation? So all of these are things that are important, relevant to the couple or the individual's case, that we like to identify first before treatment. So we do an in-depth analysis and a pretty detailed workup for these men. And then we have obviously a sit-down conversation about what the underlying cause is and how we can treat that underlying cause rather than the finding or the symptom. So that's, I think, the key just in general in medicine, and especially in fertility, as well as male factor infertility. Treatments include things that are basically improving lifestyle, removing bad habits like smoking, excessive alcohol use, drug use, smoking marijuana related type of supplements or certain products. Improving lifestyle like exercising regularly. If somebody's underweight, they need to gain weight. If somebody's overweight, they have to lose weight. Managing stress, avoiding any toxins or toxic environments, pollution from our environment as much as possible. Keeping a healthy diet goes without saying. Obviously, we all know that. So once we are able to improve those lifestyles or do the lifestyle modifications, which we recommend to all men who have abnormal semen parameters, as well as women who are trying to conceive, sometimes we do use hormone therapy in the form of pills or injections to improve hormonal environment. Oftentimes we try to increase the testosterone production and testosterone levels, which then will improve the sperm production oftentimes and improve the outcome. If there's any surgical management that is necessary to improve the sperm, then we can recommend a varicocele repair. If there is a blockage, if there's an infection, we treat those. If there is absence of sperm where we have to go into the testicular tissue and biopsy that sperm, we do that with our urology colleagues where they do biopsies. And we do work with highly specialized individuals who basically just simply specialize in male infertility. And they do these procedures with very high success rates. Those are typically called TESEs, testicular sperm extraction procedures. Some of those can be done simply through under local anesthesia by just aspirating the sperm, and others in severe cases must be done under the microscopic approach, where we are able to dissect off the testicular tissue under anesthesia, obviously, and find the sperm. We, as a matter of fact, had a case earlier this week where one of my colleagues did sperm extraction under the microscope at our surgical center, which is right adjacent to our laboratory, and we were able to find sperm immediately from that biopsy. So why don't I stop here? Because we have another 15-20 minutes for the whole session to be completed, so I can perhaps answer any specific questions that our audience or people who are taking their lunch break with us, and I can hopefully answer those questions. And if there's any need for any further clarification on any issues, we welcome you to contact us for a consultation where you'll have more private one-on-one time with me. And with that, I'll be able to review medical records if you have, and then specifically recommend what you need and talk about treatment options at that time. Today, obviously, answering every single question or going over the history of every single person will be difficult for the interest of time, but you do have the option to schedule that one-on-one meeting, or if it's on telephone, if you're out of state or out of country, we also offer Skype, telephone, video consultations. So please go ahead and exercise that option. But thank you very much for listening to me, and I'm open to answering any questions you may have.
While everybody's thinking, I do have a question myself. How common is the male factor issues arise? So, for example, mobility or that kind of thing. How common do we see where we have to go in and really take some time to treat the male instead of the female?
Right. So, I mean, male factor is very common, as a matter of fact. People say it's only 10 or 15% where the male factor is the sole cause, and that may be the case where there's severe problems with the sperm, and that is the only issue. But oftentimes when we are working with the wife or the female partner, and we do find a reason, let's say the tubes are blocked, or there's something obvious, like there is a low egg reserve. Low egg reserve, by the way, is one of the most common issues that we treat throughout our 4 locations in Southern California, including our international patients who come to our center. So that is the most common issue. Low egg reserve, high FSH, low AMH, or failed IVF cycles is one of the most common things that we treat. But when we concentrate on the female side and we check the AMH, it's low, or the egg reserve is low, we say, okay, well, that is the underlying cause of infertility, which is obviously the case. But when we do a semen analysis, we oftentimes find abnormalities in the semen analysis as well. So either the motility is low, morphology is very low, or the quality doesn't look good. Sometimes fragmentation is high, or volume is really limited, where the overall outcome is going to be affected not only by the low egg reserve, but also at the same time from the sperm parameters. So in those cases, we also have to work with the sperm. We have to improve the sperm at a minimum. And if not, we have to use certain techniques in our laboratory where we have to find out the best available sperm to fertilize the eggs that we take out. So it's just not only the female side, but also the male side. Oftentimes we run into issues where we then have to address both sides. And I think there's one question that came up, yes. I think, right?
Yes. So a woman says she has, her husband has been tested and all his tests are
okay.
Each level with so the question is, with a healthy sperm count, can that help the IVF process? And just so you know, she says she's 35 and he is 33 years old.
She's 35 and she has low AMH. So she definitely needs IVF treatment, because when you have low egg reserve, that really becomes the best treatment regardless of age for those individuals. When the sperm is normal, that's good, because that is one less thing to worry about. And this couple, they're both young, obviously, 33, 35, that's very young. But for some reason, she has low egg reserve. And once again, as I just told a couple of minutes ago, this is one of the most common issues that we treat in our laboratory, in our clinic. And we have specific treatment protocols for those individuals, where we try to maximize the number of eggs we can get, and more importantly, the quality. In terms of the sperm variable, we would still like to challenge the sperm in the laboratory, pick up the best sperm, and inject the sperm that's the strongest, because we're going to have very limited number of healthy eggs or chromosomally normal eggs that we really don't want to take a chance of having or using abnormal sperm, or suboptimal sperm, at least. Let's put it that way. So still in those cases, we still would like to choose the sperm, use the best sperm available, because we're going to be challenged on the egg side. At least we have the luxury of using healthier sperm. So in their specific case, IVF with the normal sperms would absolutely be helpful.
Mm-hmm.
And that would maximize their outcome versus doing any other treatments like inseminations or time intercourse or Clomid and that kind of deal.
Mm-hmm.
They might still benefit from that to a certain degree, but the best case scenario would be still with IVF and probably ICSI, microinjection of the sperm, because even if the sperm is normal, if the egg quality is low, the outer shell of the egg, where the sperm has to penetrate through, may be way too thick.
Ah.
And if that's the case, that can still compromise fertilization.
Mm.
So even in those cases, it's really best to take control over fertilization and maximize the number of embryos that you can get, because the number of eggs is going to be limited.
Gotcha.
So that's a really key point that sometimes gets overlooked.
Mm-hmm.
But in our clinical management, that's a part of our almost routine, where we want to maximize the number of fertilized eggs or embryos, because the more eggs we have, more embryos we get, there's more to choose. And if the couple wants to do the PGT test, pre-implantation genetic testing of their embryos, then it's always good to test more embryos, because then you're going to have more normal embryos. So it kind of all adds up. So the answer would be yes, that would be helpful. And in this specific couple's situation, it'd be best to get a consultation and start treatment as soon as possible, because if the AMH is low at age 35, that means you're racing against time. I know that doesn't sound good, but that's the reality, and that's why you should do some level of intervention as soon as possible.
Gotcha. Very interesting. I learn something new every time. It looks like those are all the questions we have.
All right,
And
very good.
and
So,
I'm sorry, we do have one question that just popped in.
okay.
And she says that she has two questions, actually. She says that her husband is 39 years old and she is 40. He has been smoking weed for 17 years, once or twice a day. Um, so she's wondering if the sperm test can check his sperm quality in regards to the weed smoking. And she also says that she hasn't started to try to have a baby, but personally, she said she's not quite sure if she should go ahead and have a baby, only because of her age. She feels like maybe her age is a factor.
Sure.
So she also wants to know the second part of that question. She wants to know if weed smoking or marijuana affects the baby's health in the long run.
So these are all good questions. First of all, if she's 40 years old, her egg reserve is declining. Mm-hmm. And she needs to consider some type of intervention, especially if she has been trying for some time. Options include egg freezing, embryo freezing, or getting pregnant right away. Within those options, depending on how the sperm is, she can freeze eggs for now, and when the sperm is better, those eggs can be fertilized. That will be one option. She should check her egg reserve. So we want to make sure that the egg reserve is good still at age 40. And if it's low, then she should start with either egg freezing or another intervention, because that means the time is running out. In terms of the sperm, he should start with a semen analysis. But in men who smoke and who are chronic smokers, I really recommend the sperm DNA testing, because the semen analysis may still be somewhat normal, but the fragmentation may be abnormal. And that is much more prominent and prevalent in a way in men who have normal analysis, just numbers are okay, but the quality is poor. And then we see those cases where sperm is fine, and we say, oh, there's a lot of sperm. And then all of a sudden we do IVF or create embryos, and all of them come back abnormal, or there are genetic problems, or all of the embryos have some kind of an issue, or the quality of the embryos is very low. So sperm DNA can significantly affect the final outcome. It can affect the health of the baby. It can affect chromosomal genetic issues later in life, certainly, because half of the chromosomes come from the sperm. It's just not the egg. So in their specific case, I would highly recommend that he gets a sperm analysis or semen analysis, and he checks the sperm DNA fragmentation. Both can be done at the same time. Furthermore, because she's 40, she should get an ultrasound and blood testing of her reproductive hormones to see how many eggs she has. Based on information, a decision can be made.
Okay, great. I will just make sure she doesn't have any further questions.
Right, any follow-up questions? Let's wait for another minute.
Oh, I do have another question. It's from a woman who says she's 36.
Okay.
She had a miscarriage 2 years ago, and her boyfriend does have fertility issues. How does she know if she is still fertile?
I see. Okay. So we have to do the basic testing on this patient, which includes an anatomical evaluation of her uterus and tubes. That's called the X-ray test, HSG test, hysterosalpingogram test. We should do that to see and make sure that her tubes are open and her uterus is normal. Furthermore, we typically check the hormone levels on the first few days of the period, typically done on the third day, to better understand the egg reserve. Does she have good egg reserve? Does she have low egg reserve, or does she have above average egg reserve? And an ultrasound to look at the ovaries, see how many follicles, how many eggs she has at a given time, and also do some additional blood work to make sure that she's healthy enough to become pregnant. So these are all the tests that she can do to better understand if she has any fertility problems herself.
Great. Great, thank you for that. Okay, another question. And that is,
excuse me.
She writes, I'll just read exactly what she wrote. HSV 1 and 2 test is positive. IgM is negative.
Okay.
Is this okay to freeze her eggs?
Yes, that's totally okay. Yeah.
Okay.
So she tested positive for human simplex virus or herpes virus. It's a large family of viruses, and a lot of the people actually are positive in the population. So we rarely test for those antibodies that she got tested for. I'm not sure why she got tested. There might have been a specific reason, but we don't test those any longer because most people are positive. And if the IgG, it's an antibody, type of antibody, is positive, that tells us about the long-term immunity, which means that she had it in the past. And then the other antibody is IgM, and if that's positive, that means she may have some active disease or active viral infection. But if she's negative, it's almost irrelevant. And even if she's positive for that, at some point it will be negative because the virus typically does not come out of the body, it stays in. So at times it can replicate, it can be active again. If it's active again, then that virus can cause skin diseases like cold sores in the mouth or genitally, or certain lesions in the back like zoster kind of issues. So they can reactivate based on the immune system. If somebody's under stress, traveling, during pregnancy it can happen, or just prior to labor at times. So those stressors can actually suppress the immune system, and those viruses can be more active, and these antibodies can actually fluctuate. But if IgG is positive, that means she had it in the past. If IgM is negative, she doesn't have anything active going on. Even if she has active disease, you can just wait for a week or two, it'll go negative. So that is not a problem. She can absolutely freeze her eggs. She should not be concerned about these.
Great.
All right. Well, we have just about a minute or two left in our session today, Araba. Let's wait maybe for a little bit more to see if there are any additional or follow-up questions, and maybe we can end the session until our next webinar coming up in our schedule.
Dr. Byrak, I just lost you for a second. Can you repeat that question?
I'm sorry, Araba, you were actually breaking up. I apologize. I couldn't hear you.
What was the question you asked? Or did you just ask a question because you were breaking up for a second?
I couldn't hear you, Araba. Sorry. You're breaking up. I'm sorry. I couldn't hear you.
Oh, okay. Can you hear me now?
A little bit, yes. I think maybe the attendees may not be hearing you clearly either, so I just wanted to make sure.
Okay.
If you can actually send me a message if you like, or if you can let me know, and I can probably just talk regarding that.
Okay, I just sent a message to our attendees asking if they can hear. They said they can hear me fine and hear you fine. So I'll just keep going. I did want to mention to all our attendees that you will receive a complimentary consultation with Dr. Byrak at your earliest convenience. So if you give us a call, then we can set up that appointment for you. Just so you know, it is normally a $350 consultation, so it is beneficial for you to go ahead and schedule that with Dr. Byrak. And thank you again for joining us. We will have our next webinar on December 18th, where we will be talking about egg freezing specifically. So thank you so much for everything, and please, you will also get an email from us after this webinar with our phone number and all of the information that you will be needing for your consultation. I appreciate it, and thank you, Dr. Byrak.
Thank you so much, and thank you for listening, everybody. Have a great afternoon.
Okay, bye-bye.
Bye-bye.